about radiation safety. So, as all of us are vascular and endovascular surgeons, so on a day-to-day basis, we are exposed to radiation, and all of us should be aware of the adverse effects of the radiation, and we should all know how to limit the radiation dose and the protective measures against that. So radiation exposure for diagnostic procedure is generally very low, which is comparable to the natural background dose. But the therapeutic dose of radiation involves a higher level of exposure, which is harmful for the human beings. So radiation poses risk to the workers as well as the patients. Nowadays, percutaneous angioplasty and stenting of peripheral and carotid arteries, as well as endovascular stent grafts for treating abdominal and thoracic aortic diseases are the first-line treatment options. And moreover, advanced techniques such as advanced grafts for abdominal aneurysms that may carry significant radiation exposures to the surgeons as well as the patient. So to address all this, radiation safety principles are being laid down by the International Commission of Radiological Protection, ICRP, and the National Council on Radiation Protection and Measurements, NCRP, which provides valuable resources and publications that disseminate information and recommendations about radiation exposure and the protection against them. So there are two types of radiation. One is non-ionizing radiation and ionizing radiation. Non-ionizing radiations which are harmless to the human beings, like ultrasound, MRI, laser, and microwave. How to quantify the radiation? There is absorbed dose, which is the amount of energy deposited in a medium by ionizing radiation per unit mass. It equals to the amount of heat generated by the radiation per unit tissue weight. So the SI unit of absorbed dose is grays, where 1 gray is equal to 1 joule of energy absorbed per kg weight. So previously used unit was radiation absorbed dose, where 1 gray is equal to 1 rad. It is not a good indicator of biological effects, as different types of radiation produce different degrees of damage. So for this, there is a concept of equivalent dose, where measure of the radiation dose to the tissue that takes into account the different degrees of damage by different types of radiation. So for every type of radiation, there is a radiation weighting factor, WR, where equivalent dose is equal to absorbed dose into the radiation weighting factor. So radiation weighting factor for X-ray and gamma rays is equal to 1, and for protons and neutrons, it is equal to 3 to 10. The SI unit of equivalent dose is sievert. The earlier used unit was Röntgen equivalent man, where 1 sievert is equal to 100 rem. So as we are using X-rays for the fluoroscopic interventions, and the weighting factor for X-ray is 1, the sievert and the gray unit are roughly equal. So the absorbed dose is equal to the equivalent dose. So one more concept is there, effective dose, where different tissues and organs, they have different sensitivity to the radiation. So there is a tissue weighting factor according to the radiosensitivity of various organs. This is also measured in sievert, and gray and sievert, they generally quantify a large amount of radiation, which is we are not exposed to that much of radiation in our day-to-day practice. So medically used radiation, that is described in milligrays or millisieverts. So now the effect of radiation, that is classified into two types: deterministic effects and stochastic effects. Deterministic effects are dose dependent and result in cell death, like impacting the hair follicles, skin, subcutaneous tissue, and lens. So acute events, when a threshold level of radiation has been exceeded, they cause deterministic effects. The higher the dose, the greater the injury to the tissue. So doses required to produce deterministic effects, they exceed 1 to 2 sieverts. Examples of deterministic effects are radiation dermatitis, cataract, infertility, or organ atrophy or fibrosis. This is the image showing radiation dermatitis of the face, and the other one radiation-induced skin necrosis. Acute whole body exposure of 0.5 to 1 sievert exposure that may produce light radiation sickness. 1 sievert can cause slight blood or bone marrow changes, and 2 to 3 sievert can cause nausea or that 50% of individuals within 30 days of exposure. And doses higher than 6 sievert, that is generally fatal. This is the chart showing deterministic effects and threshold doses of the radiation. So here we can see if a single dose exposure of 0.1 sievert to gonads, it causes temporary sterility, and 3 to 6 sievert to gonads causes permanent sterility. And we previously seen that acute radiation sickness might be there with a whole body dose of 1 sievert. Now the other thing is stochastic or probabilistic effects. They are caused by DNA. They cause DNA damage to a single cell, which results in mutation. So this is a all or none phenomena. Whether the cell will either the cell will get damaged or it will not be damaged. So it is so as the radiation exposure increases, the probability of this damage increases. So theoretically, it can occur even at low doses, but the doses less than 100 millisievert per year, the probability of these effects is very low. So probability of fatal cancer with radiation exposure is around 4%, 4 per sievert for lifetime dose equivalent, or it can be equivalent to 0.004% per millisievert, so which is very, very low. Non-fatal cancer risk has been estimated at 0.8% per sievert. Increase in cancer risk has been demonstrated to exposure doses less than 100 sievert. But a latent period of 2 to 5 years is required for leukemia, and around 5 years for thyroid cancer, and 10 or more years for other cancer is required to become manifested. This is a table showing effective doses in common diagnostic procedures. Like a chest radiograph, the effective dose is 0.02 millisievert, whereas a abdominal radiograph, it causes 1 millisievert of exposure. A CT scan of the head causes 2 millisievert, and a CT scan of the abdomen will give 10 millisievert of exposure, whereas a CAG will give 5 to 15 millisievert of exposure. Now the recommended dose limits 1 millisievert per year is the recommended dose for general public, and 80% of this exposure is from the natural sources. Rest of the exposure is from the man-made sources such as radiographs and CT scan. For dose is 20 millisievert per year, averaged over 5 years, which is not exceeding 50 millisievert in any single year. For occupational exposure, the risk of health effects is too small at doses below 50 to 100 millisievert. This is the ICRP safety dose limits. Whole body, as previously said, the whole body effective dose of less than 20 millisievert per year, or averaged over 5 years, is the safety dose limit. For lens, it is 20 millisievert per year. Skin, it is 500 millisievert per year, and extremities also it is 500 sievert per year. And for pregnant women, this safety dose limit for the fetus is 1 millisievert. So use of radiation in medicine, it should be justified every time. So diagnostic and information or the therapeutic use that should produce more benefit rather than the harm to the patient as well as to the treating physician. So we have to ensure that radiation equipment is properly maintained to deliver lowest possible dose of radiation. And we have to ensure that safety instructions and protective measures are always available and adopted. All procedures involving ionizing radiation, that they all should be monitored. The risk limits for patients as well as staff should be determined beforehand. The system of reporting and remedial measures should be in place wherever the recommended limit is exceeded. Special operating procedures should be available for high-risk individuals such as pediatric patients and pregnant women. So the radiation safety in diagnostic procedures. For diagnostic procedures, alternate imaging modality should be used that does not involve radiation, such as MRI, USG, that should be considered whenever it is possible. In less essential situations, we should request for lower dose examinations and wider pitch and partial rotation instead of large number of overlapping scans. Use of techniques such as automated tube current modulation or attenuation based kilovolt selection algorithms should be used for CT angiograms for EVAR surveillance. And standard and contrast or whenever possible, we should use standard or contrast enhanced ultrasound scan for post-operative EVAR surveillance. We should use DynaCT, dynamic rotational angiography, for pre-op planning, essentially for emergency situations and for post-op identification of endoleaks. That it causes 7 to 8 times less radiation than the standard MDCT. Shield radiosensitive. We should shield the radiosensitive organs wherever possible, particularly when they are not adjacent but not the part of the actual examination. For example, lens, thyroid, breast should be covered in CT scan of the head and thorax wherever possible, and gonads should be covered in CT scan of the pelvis. These all precautions are important in younger patients and females of childbearing age. Now, radiation safety in the endovascular procedures. Exposure to the operator can amount to 5 to 60 millisievert per year or 0.05 millisievert per procedure. And in all these procedures, the hands are at particular risk. 1 minute of unprotected screening time that leads to around 20 millisievert of skin dose, which can cause the transient skin erythema can happen as a result of doses of 2 sievert, which is too high a dose for a endovascular procedure. The higher doses can lead to eye damage, which can cause cataract. Chronic exposure will increase the risk of cancer like thyroid, brain, and skin cancer, which is also very rare. Exposure to a patient in cath lab with 10 minutes of fluoroscopic time is equivalent to around 200 to 400 chest radiographs. Fluoroscopy should be intermittent and never used unless the operator is looking at the monitor. Only essential persons should be there in the room, and ample warning signs should be displayed at all the entrances. All staff not essential to the procedure should leave the room during the serial exposure sequences or stand behind a barrier sheet wherever possible. All equipment should be regularly serviced and inspected. And newer machines which generate lower energy and have better image intensifiers, they have dose reducing features such as pulse fluoroscopy and provide better quality images. They should be used wherever possible. Now, for the prevention of these radiation exposure, we have to take certain measures. So first of all, it is the emission control. So in emission control, voltage of the fluoroscopic tube that controls the penetration of the beam and contrast of the images, and the current is the one which determines the number of photons produced. So if we are using a higher tube voltage and less current, that will reduce the radiation and will not affect the image quality. So pulse fluoroscopy, which emits short bursts of energy, should be used instead of continuous fluoroscopy. Large image intensifier should be used, which requires less radiation than a smaller one. There should be limited use of magnification, as the magnification causes 2 to 3 times more radiation exposure. X-ray field collimation and filters should be used wherever possible. Now the other thing is time. So we should put a timer which produces an audible warning at end of every 5 minutes interval, so that the operator should know when the 5-minute fluoroscopy time is over. We should make a habit of noting total fluoroscopy time and the patient absorbed dose at the end of the procedure. DSA should be used, which can result in 10 times more radiation than fluoroscopy. So its use should be limited, and wherever possible required, then only it should be used. And it accounts for almost 60% of total personal dose. Use of cine fluoroscopic acquisition should be limited, and an attempt should be made by operators to maintain a distance and or leave the room whenever activating this cine fluoroscopy. Now, distance from the X-ray tube. So we should always maintain a distance from the X-ray tube. The amount of scatter radiation that decreases with the square of the distance from the tube. So exposure is equal to 1 divided by diameter square. So radiation dose will diminish 4-fold if the distance from the operator is doubled. We have to keep the image intensifier as close to the patient and the tube as far as possible from the patient. Transfemoral procedures will incur less exposure than the transbrachial and transradial procedures, up to a level of 2 to 7 times. Because in transbrachial and transradial, we are operating near to the image intensifier as well as the X-ray tube. Radiation exposure varies with the angulation of the tube as well. So left anterior oblique view exposes the operator on the right side of the patient and anesthetist to the greatest amount of radiation. This can account for around 3 to 5 times more radiation than a right anterior oblique view. Changing the beam angulation during prolonged procedures to spread out the radiation and reduce skin dose. We should keep on changing the beam angulation during prolonged procedures to spread out the radiation and reduce the skin dose to a particular area. So, like previously said, the fluoroscopic table should be as high as possible so that the tube is away from the patient, and image intensifier should be as close to the patient to decrease the exposure. Now the barriers we have to use to prevent the exposure. So table side shield, leg shield should be used always to protect exposure to the leg and feet. That reduces the exposure 2 to 5 times. There is a dose reduction. Ceiling mounted mobile lead acrylic sheets, they reduce the doses to the head and neck by a factor of 2 to 10. Mobile rolling shields should be used for additional staff like nurses and anesthesia team. Lightweight disposable lead drapes can be used. They are made of mostly tungsten, antimony or bismuth. They should be used and they will reduce the scatter radiation. They reduce the dose generally to the head, hand and upper body by a factor of 5 to 25. They should be kept away from the primary beam so that they do not hinder the imaging, and they can also be fabricated from the scraped aprons and shielding which has got damaged. All the staff should wear protective lead aprons. 0.25 mm lead equivalent aprons, they attenuate around 96% of radiation dose, and 0.5 mm attenuates around 99% of radiation dose. The front of the apron should always be kept towards the X-ray tube at all the times. Lead glasses with 0.7 mm lead equivalent, they reduce the dose by 90%. Thyroid shields, they reduce dose by a factor of 5 to 10. If they are worn loosely around the larynx, around 1 centimeter of the upper thyroid is unprotected. That reduces the protection factor by a factor of 5. So they, as far as possible, they should be tied tightly. Protective gloves with 0.35 mm lead equivalent, they are less widely used because of the reduction in the tensile sensitivity. They can also be used, but if they are reducing the tactile sensitivity, they may increase the fluoroscopic time more. So nowadays there is bismuth-based hand creams that can be used over the hands, and over that we can wear sterile gloves. All the protective gear should be inspected at least yearly and replaced if they are defective. Now coming to the technique, if even a straightforward procedure can result in significant radiation exposure if the technique of the operator is poor. So and the monitoring the exposure, radiation dosage should be monitored by dosimetry. TLD batches and this thermal luminescence dosimetry batches should be used, and 2 batches should be used at a time. One should be worn under the apron, which can ensure that the whenever we will see the radiation exposure, we will see we can make out that the operator was wearing the apron all the time, and how much effective is the apron in reducing the radiation dose. So one has to be worn under the apron, and second has to be worn over the apron at the collar level, which will show the level of radiation exposure to the eyes as well as to the thyroid. If a patient is exposed to a higher doses of a level of more than 3 to 5 grays, the follow-up should be done in 1 to 2 weeks to look for any harmful effects. Ho and colleagues, they did a prospective study of the endovascular procedures in their practice over a period of 12 months. So what they did did all the procedures that were done with mobile fluoroscopic units in an operating room using all the protective barriers. So total of 150 procedures were done in that 12 months period, in which 30 were aneurysms, 60 procedures were diagnostic angiograms, 60 were angioplasty and stenting. So average of 500 to 700 minutes of annual fluoroscopy time was there. So they calculated that median yearly effective dose of 0.2 millisievert each for whole body and eye, and 1 millisievert for the hand for these 150 procedures, which was significantly below the ICRP recommended dose limits. So with all this data, they got an inference that vascular surgeons has to perform 2600 endovascular aneurysm repairs or 6500 peripheral procedures annually to reach the dose limit recommended by ICRP. Now, radiation in pregnancy. So radiation risk to the fetus is very small in comparison to the risk of spontaneous abortion, genetic abnormalities, and malformations in general population. So undue anxiety and termination of pregnancy may result if a patient and staff is not properly educated about the risk of radiation exposure. So it is recommended that an occupationally exposed pregnant woman, she should declare pregnancy for the purpose of reducing the risk to the unborn child whenever they come to know about the pregnancy. Once the pregnancy is declared, additional precautions should be adopted to protect the fetus and to limit the radiation exposure to the recommended levels. So, risk being high, the risk of radiation exposure is highest during the organogenesis in the first trimester and least in the third trimester. Whenever possible, diagnostic tests and procedures that involve radiation, they should be deferred or replaced with safer options. Doses are generally highest in the later trimesters because of the bigger size of the fetus. Lumbar spine AP radiographs at 3 months of gestation that may result in about 2 millisievert of exposure, which increases to 9 millisievert when performed near term. CT scan of the head of the mother results in around less than 0.005 millisievert, but an abdominal CT scan can lead to 8 millisievert of the fetal exposure. Major adverse effects to the fetus include abortion, teratogenicity, mental retardation, IUGR, and induction of cancer. But they are very rare with all this lower level of radiation doses. Normal diagnostic procedures would seldom involve sufficient doses to induce malformations, fetal death, CNS defects, but the threshold may be exceeded with complicated interventional procedures. Central nervous system malformations may appear if a dose of threshold of 100 millisievert has been exceeded. Fetal dose of 100 millisievert or higher, if incurred between 8 to 16 weeks of pregnancy, they can be associated with reduction of intelligence and microencephaly. So the pregnant workers, they may work in a radiation environment as long as it is determined that the fetal dose can be kept below 1 millisievert during the course of the pregnancy. With such doses, radiation should be should have negligible effects on the fetus. Properly sized protection should be worn at all the times. But these lead aprons, they may present other health hazards to the pregnant lady, such as back strain. Fetal doses approaching 100 millisievert pose a small risk of radiation-induced cancer or leukemia, which is minimal in the third trimester. And if a worker has declared pregnancy while having been exposed to the radiation, it should be ensured that any additional dose to the fetus would not exceed 1 millisievert during the remainder of the pregnancy. Thank you, sir.